Good morning. I'm Tim Sheehy, President of the Metropolitan Milwaukee Association of Commerce, and welcome to the Business of Metro Milwaukee. This webinar puts a spotlight on the challenges and opportunities we face in sustaining and growing the region's prosperity, providing insights to help your business and inspiration to shape the region's future. Today's program is sponsored by United Healthcare. United Healthcare partners with MMAC to make it easier to find a health plan that works for your employees and your bottom line. When you work with an MMAC affiliated broker, you'll receive discounted rates on United Healthcare's All Savers plans. You also have the option to add other United Healthcare plans to your employee benefit package, such as specialty plans and supplemental financing protection plans for groups with as few as 5 employees. So contact your MMAC broker or visit MMAC.org to learn more. Well, we're thankful again today to have Dr. John Raymond, President of the Medical College, joining us for an update on all things COVID. And he'll be followed with a discussion with Kathy Jacobson, President and CEO of Froedtert Health, and our newly elected chair of MMAC to share some insights on the year ahead. And then just a note on programming, we will continue to have this program. This will be the last one of the year, but we'll pick it up again on the front side of 2022. So with that, I'll welcome Dr. Raymond in to provide us with an update on the ever-changing impact of variants on our economy. Dr. Raymond?
Yeah, thank you, Tim, and good morning, everybody. It's a pleasure to be here with you today. If we could get to the first slide, thank you. These data are from yesterday, either from the Wisconsin Department of Health Services, the Wisconsin Hospital Association, or the New York Times COVID Tracker websites. So starting at the upper left, we continue to have a very high burden of new cases in Wisconsin, primarily driven by the Delta variant, which we've been dealing with now for the last 3 months. Our average is unfavorable. It continues to rise. And the 7-day average yesterday was reported to be 3,457. And that average does not include presumptive cases, some of which later on will be characterized as a positive case. So continuing challenges for us. The positivity rate, which ideally should be less than 5%, is trending unfavorably and is high at 11.7%. What that means is there's probably a significant burden of community transmission and new cases that we're not detecting. And then finally, on the upper right, the R value continues to be above 1, which means that the pandemic trajectory is going in an unfavorable direction. Going to the bottom of the slide, these data are pulled from the New York Times website. Looking back over the last 2 weeks, we've had a 17% increase in average daily new case counts that are reported, and a 25% increase over the last 14 days in our average hospital census from COVID-19. A little bit of good news, we're at the top of the middle of the pack in terms of vaccinations, which can mitigate some of the severe disease of COVID-19. So we're 21st out of 50 states with 61% fully vaccinated. Next slide, please, Chris. These show death and hospitalization data starting at the upper left. Unfortunately, our daily reported deaths are trending in an unfavorable direction, in other words, upwards, now averaging 23 over the last 7 days. And recall that late in August and early in September, we were having low single digits reported in terms of daily deaths. So clearly going in the wrong direction. Hospitalizations also are trending unfavorably. In other words, they're increasing now to over 1,700 yesterday. And to be perfectly frank with you, I was not expecting us to have hospitalizations rise to this level, considering how many people we have that are vaccinated. Compare that in the middle of the right-hand side of the screen in the green bar to our peak of nearly 2,300 hospitalizations from COVID back in last November. And I do want to disclose here so that people don't misunderstand, 88% of the people in Wisconsin who are currently hospitalized with COVID are not vaccinated. Okay, moving to the upper right, 443 COVID patients in Wisconsin intensive care units. Again, very close to the peak that we saw last November. I would not have predicted this, but it is a challenge for us to have that many of our ICU beds occupied by critically ill COVID-19 patients. Going to the lower left-hand side of the screen, also some challenging news for us. Our intensive care units are at 97% occupancy, and contrast that with the peak of 96% 1 year ago when we were experiencing the peak of the Alpha surge. Also, our hospital bed utilization is extremely high at 93%. Contrast that to the high that we saw last November of 92%. And then on the bottom right shows the intensive care unit census here in southeastern Wisconsin. We have about 45% of the beds, so it's not surprising that our ICU census would be nearly full at 212, as you can see on the bottom right. Next slide, please. These are screenshots from the Department of Health Services website as of yesterday. I've circled on the top 3 areas that can show you the trends in terms of new confirmed probable cases and the percent positivity by tests. And you can see that we continue to be challenged not only with a high burden of disease and a high positivity rate, but at least a trajectory that is not trending favorably and probably is going in an unfavorable direction. Next slide, please. I like to show this slide because it demonstrates the burden of disease in our 72 Wisconsin counties at selected periods of time over the last year. Starting at the left-hand side of the slide, red is bad, dark blue is almost as bad, and lighter blue shows decreasing case burden reported in the previous 2 weeks. So these are 2-week averages of cases reported in Wisconsin's 72 counties. So again, starting at the left, a lot of critically high burden in our counties with a handful that had very high. When we started vaccinating people in January, we started to see a significant decline in the burden of disease, again, driven largely by the Alpha and Beta variants. And as you can see on the third from the left, that picture of Wisconsin shows that we were in pretty good shape around July the 4th with a low case burden on average across the state of Wisconsin. Unfortunately, Delta hit us in August and late July. And what you see on the far right is an example of what we've been seeing for the last 4 to 5 weeks. About a third of our counties with a critically high case burden, and most of the rest with very high case burdens. I would point out that it looks like the peak that we're experiencing now isn't quite as bad as what we had last November, but the average across the state is critically high and higher than we actually saw last November. We're at about 950 cases per 100,000 reported in the previous 2 weeks. I also would point out that our staff are exhausted, even more so than they were a year ago. And staffing is the critical variable in terms of our ability to respond to surges and to keep functioning at a high level when our hospitals are full. Next slide, please. Also want to show that what we're experiencing here is part of a trend, primarily in the northern part of New England and the Great Lakes region. And I've circled 6 states, which you can see here: New York, Pennsylvania, Ohio, Indiana, Michigan, and Illinois, that over the previous 2 weeks had 60% of the new hospitalizations in the US. Those same states only account for 35% of the US population. So clearly in this swath of states from New England all the way through Minnesota, we're experiencing rising hospitalizations. And that is a trend that's unfavorable compared to the rest of the country. Next slide, please. Now I want to pivot to a new variant that I'm sure people are hearing about and thinking about a lot. And I want to give you some information about what we know and try to pose some questions that still remain to be answered. So first of all, this new variant can be pronounced a number of different ways: Omicron, 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 which is Boris Johnson's favorite pronunciation, or Omicron. All of them are legitimate and I think convey the same variant. It's also called B1.1.529. Now, what's different about this variant is that it has a staggering number of mutations, 4 dozen mutations, most of which are in the spike protein, and at least 15 of which are in the receptor binding domain, or at the tip of the spike protein that binds to mammalian cells. Many of those mutations are predicted to make it more transmissible and to change the proteins in the spike protein. If you have enough of those mutations that change enough of the sequence of the protein in the spike protein, then maybe our antibodies can't recognize that spike protein as easily. And so there are concerns about immune evasion. This variant has been detected in over 7 countries and now in most US states. Now, it still represents a small percentage of the cases in the US, but that is very likely to change very rapidly and very dramatically in the coming weeks. It is clearly much more transmissible than the highly contagious Delta strain. Some estimates would suggest that it's anywhere from 2 to 4 times more contagious than Delta, which is breathtaking in many ways because Delta is 30 to 50% more transmissible than the Alpha strain, which was 30 to 50% more transmissible than the original Beta strain. So we're talking about a quantum leap in terms of contagiousness. And the evidence that I'm citing is very solid, but very recent. We have just about 4 weeks of experience with this variant, predominantly from South Africa, but also in the last week, a dramatic increase in Omicron expression in the United Kingdom. And as of yesterday, it became the dominant variant in the UK. That's likely to happen here in the US anytime from 2 to 5 weeks from now. Now, some other things that we know that may be troubling for us. Previous infection with COVID-19, whether it's beta, alpha, or delta strains, or so-called natural immunity, and vaccines provide less protection against infection with Omicron. That was a maybe a few days ago. The data that have been coming out from South Africa now are pretty clear that there is a reduced effectiveness of vaccines and virtually no protection from previous infection. And I'm going to talk a little bit more about how we quantify that in a minute. I also want to make sure everyone knows that there are 2 versions of Omicron that are circulating. One is called BA1 and the other BA2. This latter one is called a stealth version because it's not detected by a PCR shortcut that many labs are using called SGTF. That's probably too much down in the weeds, but I do want to set the stage for the potential that BA1 and BA2 may behave differently going forward. We just don't know enough about these strains to say that for certain. So I do want to talk about vaccine protection. We now know from data that was presented this morning in preliminary form from Discovery Health, which is an insurance company in South Africa, that they have suggested that the Pfizer vaccine's protection from infection drops from 80% to 30% for the Omicron strain. Somewhat good news is that the protection that we get from severe disease drops, but not as much. It goes from 90% to 70%. So what that means, if we can translate those data to our populations in the US, is that people currently categorized as fully protected, in other words, people that have had a full course of Pfizer or Moderna, which would be 2 shots, still are protected from severe disease, hospitalization, and death by about 70%. But that protection is less than what we were enjoying with other strains. And so the CDC, the World Health Organization, the South African Medical Society, and many other public health entities are strongly suggesting that people that have received 2 doses consider getting a booster within the next few weeks before Omicron circulates in the US at high level. Next slide, please. Now, what's different about Omicron? I already mentioned it clearly is more contagious. We also know that the incubation period or the latency period from exposure to expression of symptoms is much shorter than with other strains, on the order of 1 to 3 days versus the usual 5 to 7 days. the doubling time in populations is astonishingly fast. There's a doubling of expression of Omicron in populations in anywhere from 2 to 3 days. Now, maybe on the good news side, the symptoms do seem to be milder, at least in South Africa and preliminarily in the UK. The symptoms are cough, stuffy or runny nose, headache, fatigue, scratchy or sore throat. Maybe the kind of symptoms you would get with a head cold or with the flu. Although, again, this remains to be determined in larger population sets in other countries. But if it is true that the disease is milder, that could be a lucky break for us. The symptoms also seem to resolve more quickly than in previous strains. Again, people get sicker, but not as sick, faster, and then things seem to resolve quickly. Now, some caveats. The populations impacted thus far, primarily in South Africa, have been younger with an average age of 38 and a half. A lot of the initial outbreaks happened in universities and college settings, and predominantly among vaccinated individuals who would have, as we mentioned, 70% protection from severe disease. So again, in South Africa, there's been a lower percentage of people with the Omicron variant who have severe symptoms, a significantly lower hospitalization rate, significantly lower oxygen requirements, and significantly lower ICU use and deaths, just a few that have been reported so far than with previous strains. So we'll watch this carefully in the UK and hope that the disease actually is milder. What we also know and suspect is that vaccines, monoclonal antibody therapies, and previous infections with COVID-19 are predicted to give reduced protection from infection, and there's accumulating evidence that all of those things do have reduced protection. Next slide, please. Okay, I just want to talk about a few things, and again, we're going to know more in a few weeks, but I want to compare and contrast two statements that were made yesterday and the day before. First by UK Prime Minister Boris Johnson, who very cautiously said about Omicron yesterday, the idea that this is somehow a milder version of the virus. I think that's something we need to set on one side and just recognize the sheer pace of which it accelerates through the population. And I think what he's saying is, even if it is less severe, there are going to be people that are sick. And if we all get sick at the same time, it could overwhelm the health systems. Now, compare and contrast that with a statement made 2 days ago by Dr. Angelique Coetzee, who's the chair of the South African Medical Association. She said that after 4 weeks, and this is now the 4th week in South Africa, there's no reason why you can't trust us when we say to you it's mild disease. So these are two conflicting statements that are going to need to be resolved through the experience that the UK will see in the coming weeks and that we will see probably starting in early January here. Next slide, please. So some key questions, and I'll try to give you the best estimate of the answers as of what we know today. And obviously this is an emerging understanding for a lot of aspects of Omicron. And so we're going to know a whole lot more in the days and the weeks to come. But is the Omicron variant more contagious than other strains? I think the answer is a definitive yes. Again, in the early phases of community spread, Omicron could be 3 to 4 times more transmissible than Delta, which I want to remind everybody is one of the most contagious viruses that we've ever dealt with, being in the same order of infectiousness as chickenpox. And it is predicted and very likely that this will become the dominant variant in the US by the end of January 2022 and possibly sooner. Another question is the disease caused by Omicron milder than the disease caused by Delta? Probably. I would even say likely. I believe that the preliminary reports from South Africa are valid. They're coming from multiple reliable sources, large health systems, the South African Medical Society, and insurance companies. But recall that the people in South Africa have largely been vaccinated and have been younger. We really need to be careful and look carefully at what happens when there will be an outbreak among vulnerable populations, a transplant unit, a cancer unit in a hospital, or perhaps a nursing home. And I'm sure that we'll have more information about that shortly. Next slide, please. Are COVID-19 vaccines effective against Omicron variant? Probably, I think I would now lean toward yes, based on data coming out of South Africa over the last 48 hours, but with a reduced effectiveness. And I want to anticipate the question, why bother getting vaccinated? Why is the CDC and why is the WHO recommending people to be vaccinated or to be boosted against Omicron? I'll point out that the data about Pfizer suggests that even with 2 doses, that we still get very substantial protection from severe disease, hospitalizations, and very likely death, on the order of a reduction of 70%, which is quite good. Although, again, in the interest of full disclosure, not as good as the protection that we were getting from the previous strains, which were on the order of 90%. Are the monoclonal antibodies that people have been using for early mild infections still effective against the Omicron variant? Regeneron and Lilly, which are the 2 cocktails used early in infections, probably lose some effectiveness against Omicron, and they were modestly effective to begin with. It remains to be seen whether those will still be recommended as the standard of care as the burden of Omicron in our communities rises. We just don't know enough about it, but there's pretty good evidence that they will lose some effectiveness. On the other hand, GSK Vir product, which was just FDA authorized last week for long-term protection for people that can't mount an immune response. So for example, people with cancer, lymphoma, leukemia, they say yes in their preclinical studies that they have very strong evidence that this monoclonal antibody cocktail can give significant protection against Omicron. So it may depend on the product. Next slide, please. Thank you, Chris. Will the rapid antigen tests that we can buy at CVS and Walgreens for $23 still work? And the answer is yes. The companies that manufacture these tests have already done tests against Omicron, and these tests do recognize this variant. But one caveat that people need to consider is that because people get symptomatic quicker, that this test may not be good for as long as we think it should be good. I mean, generally, people feel comfortable that if you take a rapid antigen test before you congregate with family, that you're pretty good for that day. Let's have some caution about how long these rapid antigen tests are good for, because there are about 20% of the cases that are false negatives with these tests, and they're generally people that are infected but have a low viral burden in their nose, and they're on their way to getting symptomatic. So again, if you get symptomatic quicker, these tests may not be as good for as long as we've enjoyed for the other variants. Will the polymerase chain reaction, the gold standard test, recognize the Omicron variant? Yes. As I mentioned, there is one PCR shortcut that misses one of the 2 strains of Omicron with this technique called S gene target failure, but that can be easily worked around inexpensively. Next slide, please. Will the currently available drug treatments work against Omicron? And I think the answer is almost certainly yes. These drugs work differently than the vaccines. They work on the internal machinery and interfere with replication of the virus. The sequences that code for those proteins are not mutated in Omicron. And there is preliminary evidence that the products from Gilead, which is remdesivir, and Merck's molnupiravir, which is a pill that was recently FDA authorized, work well against Omicron. And Pfizer, which has applied for emergency use authorization for Paxlovid, which is another pill to be used early in the treatment, both in theory now and in the laboratory, is very effective against all COVID strains, including Omicron. So that's a little bit of good news for us. The next slide, please. So what's next? Our current challenge is the Delta variant and full hospitals with no relief in sight, with people congregating indoors because of the holiday, because of COVID-19 fatigue, because of a sense of fatalism about COVID-19 and because of the holidays. We still have high case burdens and significant burden of community spread with a trajectory of Delta going in the wrong direction. Our hospitals and the staff capacity and resilience are strained right now. Omicron does have the potential to rapidly become the dominant strain in the US. And as I mentioned, we need to watch carefully and learn from what's going to happen in the UK in the coming days and what has already happened in South Africa. We also need to learn and think with caution about the severity of Omicron in vulnerable populations. And the CDC clearly is recommending boosters for the fully vaccinated. And there's a big question, how many people are actually going to seek that booster? Next slide, please. Before I get to this, and this just answers some questions people have about what is a mutation or a variant, I do want to basically look ahead and think about what might happen. Some people are saying that Omicron is bad and that it's going to challenge us. And that may be true in the short run. Others are saying that this is a blessing in disguise, because if you think about it, if you have a highly contagious virus that doesn't cause serious illness and can displace a more lethal virus, that could be a good thing for us. I would say that for that to be true, 4 things need to happen. First, we need to demonstrate in the US that Omicron is more contagious than Delta. Second of all, it needs to supplant Delta. Third of all, we need to see in our population that it really, Omicron does cause mild and not severe disease. And then finally, and we don't know this yet, that Omicron can give us an immune response that protects us from future infections. So those are the 4 conditions, I think, that need to happen for us to say maybe Omicron is good news. Now, my last slide here just addresses how do viruses mutate. First of all, it is normal for every virus to mutate every time that somebody gets infected. Every replication or duplication of the virus is an opportunity for it to mutate or reinvent itself to try to gain a competitive advantage. This is expected. For the COVID-19 viruses, their genetic sequence is coded for by ribonucleic acid or RNA. This codes for sequences of amino acids, which are the building blocks of proteins. So that message is then translated into these proteins, the amino acids that are assembled into a protein. Now, if the RNA code is mutated at one spot only, it could change a single amino acid, which might result in reduced antibody binding. So if you look at the bottom left, you can see the normal situation in which the message RNA is translated into a protein, and then an antibody binds to a specific site on that protein. The middle panel shows one mutation in the message that is converted to a different amino acid. And so there may be slightly reduced antibody binding if there's only one mutation. But if you think about Omicron that has dozens of mutations, it's possible that there could be many different mutations, many changes in the amino acid building blocks of that spike protein that could render antibody binding relatively ineffective. So this is what we're going to need to look out for in the coming weeks. And I thank you for your attention. I'll turn it back over to Tim.
Thanks, Dr. Raymond. Maybe one question here. I know you've got a time constraint, and I want to welcome Kathy into the conversation. But of the 12% that are hospitalized that have been vaccinated, do they have underlying conditions, or is that a breakthrough?
Yeah, thank you, Tim. And it's really an excellent question. Yes, they are breakthrough infections largely happening in people over the age of 65 or people that have some pre-existing comorbidities like diabetes, obesity, hypertension, cancer, kidney failure, the usuals. So again, the vaccines and boosters give us some degree of protection, but still there are vulnerable populations that can suffer severe disease.
And then maybe one last question for you. How long do you have to wait to get a booster after testing positive for COVID?
Well, the previous recommendation was 2 months after the J&J single shot. and 6 months after either the Pfizer or the Moderna vaccine. I think right now, because of the concern about Omicron, that people are recommending that if you're a couple months out from your booster, it's okay, or from your completion of your course, it's okay to get boosted. And so they're probably loosening up those guidelines a little bit so that people can get boosted sooner. And again, we're going to be dealing with Omicron here in a couple of weeks. So that's the current recommendation. I do see one about the J&J vaccine. If you have only received one shot of J&J and you received a second shot of another booster, you are considered to be boosted as of today, although the CDC may recommend a third shot later on. They're not recommending it right now. That's only for the J&J.
Yeah, thank you again, Dr. Raymond. Really appreciate the time, and we'll see you again in 2022.